Okay, I think the numbers are settling down now, so we'll get started. So, welcome to our introduction to the Stroke Data Science Catalyst webinar. So I'm Sarah Lessels, I'm the Research Project Manager at the BHF Data Science Centre. Today we're going to be hearing about the aims and ambitions of the Stroke Data Science Catalyst. So it's led by the BHF Data Science Centre in partnership with the Stroke Association, the Health Data Research UK and the British Heart Foundation. So I'm pleased to be joined today by Dr. Richard Francis, Head of Research from the Stroke Association, and Professor William Whiteley, Associate Director and the Theme Lead from the BHF Data Science Centre. So just before we get started, can I ask everyone to kindly keep your camera and microphone switched off, and to note that the webinar will be recorded and will be available afterwards on the HDR UK YouTube channel. We will have time at the end for discussion, so please do post your questions in the Q&A and we will do our best to answer any of the questions posted. So without further ado, I will pass over to Dr. Richard Francis.
Good afternoon, everyone. So I see a few familiar names and faces on the webinar, but I'm going to start by doing an introduction to the Stroke Association and why we're funding the Catalyst and some of the priorities that we'd like to see funded. And then after that, I'm going to hand over to Will to give a bit more information detail. So Will's going to be sharing the slides. Thank you, Will.
Can you see the slides?
Yeah, I can see the slides. It's great. Thanks. Next slide, please. So let's start with a bit of an introduction. So why stroke and why is it important? So there are over 100,000 strokes in the UK each year. And there are 1.3 million people, stroke survivors, so living with the effects of stroke. And we know this is expected to increase in the coming years, particularly with the ageing population. Stroke is the fourth biggest killer in the UK. And that's actually twice the number of people that die from breast cancer each year. We know that stroke costs about £26 billion to the economy. And this is partly due to the long-term effects of stroke and people living and needing long-term care. And that's because about 2/3 of stroke survivors leave the hospital with some type of disability. This could be physical, cognitive, or a different type of impairment that means that people need to have long-term care. Next slide, please. So who's the Stroke Association? We're the UK's leading charity dedicated to helping people that have a stroke. We provide specialist support. So this includes coordinators who go into people's homes when they come out of hospital, helping them navigate their life after stroke. Our helplines that help people remotely and give people information after they've had a stroke. We fund research, and that's the type of research that we're talking about today. And we also do campaigns, so campaigning for change in policy to ensure people have the right support and care and help them rebuild their lives after stroke. So we work really closely with thousands of stroke survivors and their carers, but also healthcare professionals and policymakers and decision makers to ensure people have the right care, and also with researchers to help fund research and ensure more research is undertaken. Next slide, please. So I said we want to see more research. We want to see more funding allocated to research. We want to raise the profile of stroke and ensure more money is allocated to stroke research. So we know that stroke is underfunded and only receives about 1% of government and charity funding. And that compares to around 9% for cancer and around 10% for other neurological conditions. And this is the main reason we conducted a James Lind Alliance priority setting partnership a couple of years ago. And this is a really gold standard methodology for setting research priorities, which brings together healthcare professionals and people affected by stroke to set research priorities. And we got about 4,000 different questions related to stroke. And then we had to work to combine these and prioritize these. So we ended up with 2 top 10 lists, and these were organized around the stroke care pathway. So we have a top 10 priorities around prevention, diagnosis, pre-hospital, and hospital care, and our top 10 priorities around rehabilitation and long-term care. And we really want these to be the priorities the researchers used to really think about the research questions and the projects that they work on. And I'd really urge you to look at the report that really outlines the detail of these, which is actually hosted on our website. Next slide, please. So we've now partnered with the British Heart Foundation, BHF Data Science Centre, and HDR UK to establish the Stroke Data Science Catalyst. We realise there's large potential for bringing together different data sets in stroke. And these include the large population level data sets, such as registries, hospital data, primary care data, and also unstructured data like brain imaging, which is obviously very important for diagnosis of stroke. And bringing this together can really help our understanding and accelerate priorities. This includes the Stroke Priority Setting Partnership, which I just mentioned, but also having a better understanding of long-term outcomes for stroke survivors and health disparities. So health inequalities is a really growing area of focus for the Stroke Association, and something we would like to see the understanding of and being addressed more going forward. We want to work with the Stroke Data Science Catalyst to collaborate, particularly around involving people affected by stroke, because obviously we have a large network of people we work with, but also working to disseminate and work with policymakers and decision makers, as well as to disseminate findings to the wider media. Next slide, please. I just wanted to highlight that the Stroke Association has our own funding, and we have our project grants, which allow people to look at specific projects, and they will be going live in the summer. And we'll also have a number of awards that are aimed at building capacity in stroke research along the career pathway, including 2 different fellowships and a lectureship award. And I would urge anyone that's interested in doing stroke research and that wants to utilize data from the Data Catalyst to have a look at these. And there's information on our website, and you can contact us at the email address here. So I'm now going to hand over to Will, and he's going to tell a bit more detail about the Catalyst and how you can get involved in working with them. Thanks.
Thank you, Richard. So I'm William Whiteley. I'm a stroke epidemiologist and neurologist in Edinburgh, and I'm delighted to be the theme lead for the Stroke Data Science Catalyst, and an associate director of the British Heart Foundation. So we're joined today by not only many people who know about stroke, but a lot of data scientists who don't. So let me just introduce to those of you who don't know what a stroke is. So strokes are diseases of blood vessels, and it's largely diseases of blood vessels in the head and neck. And that's why why stroke as an area fits within the cardiovascular theme of the British Heart Foundation, and why the British Heart Foundation, as well as the Stroke Association, are supporting us. Stroke can be due to brain ischemia, and that's when a thrombus blocks an artery in the brain, leading to ischemia of brain tissue, or where a blood vessel bursts in the brain, leading to intracerebral hemorrhage. And those are the 2 main stroke types. And the consequences of both these brain injuries are physical, psychological, and cognitive impairments in the longer term for people affected. And that's why, as Richard has outlined for us, why stroke is such a priority for the NHS, as well as people affected by stroke. So the Stroke Data Science Catalyst sits within the British Heart Foundation Data Science Centre. The Data Science Centre is led by Professor Cathy Sudlow, and its chief aim is to enable and facilitate data-led research in cardiovascular and circulatory health. It was set up at a really opportune time because it was able to really contribute to our understanding of the COVID-19 pandemic and cardiovascular diseases. And it was a real enabler for data research across the United Kingdom. And the whole team helps researchers to navigate this complicated data infrastructure and make it much easier for researchers to harness the benefits of these large population-wide data sets. It's led by Health Data Research UK. So that's the UK's Institute for Data Science in Health Data, established in 2022, and the initial investment of £10 million from the British Heart Foundation. And it's brought together an enormous expertise in cardiovascular data science, and I'll come into some of that in just a moment. If you want to find out more about the work of the centre in general, send us an email at this email below, or look at the website just by clicking the link. And what the centre does is its research sits within 6 themes, and I'm going to expand on these themes and how they're relevant to stroke. So the 6 themes are, first of all, data-enabled clinical trials. So how we use data collected by health systems to improve randomized trials and to try and answer new questions. The second theme is to try and make health systems data, that's largely data collected by the NHS, but remember we've got 4 NHSs in the United Kingdom, so to make those data from those 4 NHS organisations easier to link to cohort studies. In unstructured data, we're working out how to use imaging data from hospitals and how to look at those at scale. Within personal monitoring watches, devices, things that you have in your home, the theme lead has decided to look at prediction and measurement of cardiovascular disorders. Computable phenotypes are a really important underpinning piece of work across the centre, aims to define cardiovascular conditions in health systems data so that they are consistent between projects and generally agreed by the community. And lastly, the structured data theme, by no means least, which is where there have been a lot of outputs over the past few years, which uses whole population coded data from primary care, hospital records, death records, and many other data sets to produce insights into cardiovascular disorders across the United Kingdom. And more recently, there have been 2 condition-led catalysts to try and think about particular disease areas. So the diabetes data science catalyst is looking at diabetes, and I'm talking to you today about stroke. And of course, cardiovascular disorders as a whole are addressed by everyone else in the centre. It's really important to remember that people affected by cardiovascular disorders advise both the centre as a whole, but at each of these themes, so that every bit of research that we do is informed by people's experience, both to think about the questions we try to address, but also the way we present and share them with the community. So for some people, health systems data is a bit of a puzzle. So let me just let you know a bit about how health systems data is made and addressed. So if you're a patient and you go to see your GP or your hospital doctor or another health professional, that person will record something about you in a health system. If you go to your GP, that data is recorded in about 3 healthcare systems across the United Kingdom, one of which is called Vision. There are 2 others, and that then is held by GP system providers, but can be delivered to the NHS central organisations like NHS England, NHS Scotland, or NHS Wales or Northern Ireland. If you go to see your doctor or healthcare professional in a hospital, what they will do is record information about you in an electronic health record system, and that may be free text data or it may be coded data, and those data will usually be read by a very important professional, a coder, and they will convert that free text information into coded information recorded, for example, in the ICD-10 coding system, which many people know about. And that's then returned to the central NHS organisations where it sits in a number of data sets. Lastly, your GP or your hospital doctor or maybe a paramedic may record things about you in other unstructured forms. And perhaps for us in stroke, the important piece of unstructured data is brain imaging. And that sits within either hospitals or in national collections. So this is the ecosystem we're working with in health systems data. Now let's think about each of those 6 challenges that the BHF Data Science Centre is aiming to address. First challenge is in data-enabled trials. How are we going to think about using this for the treatment and prevention in stroke? Well, why is health systems data important for trials? Well, what we can see is that there's an enormous overlap between data that's collected by health systems and data that's needed for clinical trials. And if we could use those data that's collected for health systems, we might be able to make our trials more efficient and faster. We could use health systems data to identify potential participants, to measure outcomes that we're interested in the trial, or actually for the whole health systems data infrastructure to be part of an intervention to improve health. What we're going to think about in the stroke data science catalyst is whether we can do cluster randomized registry trials using large national audits, the Sentinel audit in England and the Scottish Stroke Care audit in Scotland. And can we use these registries to start to think about testing different types of stroke care? And this is inspired by registry-based trials that have been delivered in, particularly in Sweden, where these have delivered nationally based interventions and got trials done very quickly. So we might, for example, randomly allocate different hospitals to different interventions. So, for example, different policies of care, and measure the effect of those outcomes at a hospital rather than an individual level using data that's already collected. And we could analyze these data in the individual and hospital level data in an NHS secure environment. So we might make we might add functions to these national audits, and that would really help us to improve the kind of inferences we draw from health quality improvement. The second theme is enhancing stroke cohort studies, and that's led by Richa Sofat. So how things happen at the moment is if you have a stroke cohort study, you usually put your data into a university safe environment. And if you're going to ask for health systems data, you go to NHS England or another data custodian, and they would provide information to you in your university safe haven. So you can, for example, work out who's been admitted to hospital with a stroke from your cohort. The problem is that there are there are many hundreds of cohorts that take place in the United Kingdom each year. There are many university data safe havens, so that means there are many, many copies of NHS data sitting across multiple environments, which requires that every single environment has to work perfectly to keep the data safe. So what Professor Sofat has done has been worked on a trusted research environment based on the infrastructure used for the SAIL dataset, which some of you may have used, which would aim to bring cohorts together into one place so they can all be linked one time to NHS data. And we're looking for stroke cohorts who would like to be involved in that project. And so please contact us if you would, because we think this will make that kind of linkage much easier for you. The next thing we'll be addressing is the use of NHS brain imaging data for research. So when we have been using brain imaging data for research up until now, what we've largely been using is our own smaller research data sets, or perhaps data sets that sit in individual hospitals. And there are data sets now available to us that allow us to look at the use of diagnostic imaging at a national scale. So in front of you on the left of this slide, is research that Michelle Williams, who's leading this theme, has done in the diagnostic imaging data set that's been relevant to cardiovascular research. So what we've got here along the, if we just look along the x-axis here, we've got years, and along the y-axis scans per 100,000 people. And this, there are different types of scans in different colors that have been used for imaging in heart disease. And what we can see here is the remarkable increase in the use of CTA, a slow increase in MRI, but a slight decline in the use of PET for cardiac research. For us in stroke, what we're really interested to know about is what happens in the brain. So we're going to start looking in one place before we go out to the rest of the country. And we're going to start in Scotland, where a national data set has been set up, which takes all of Scotland's imaging in something called the Scotland Medical Imaging Service between 2008 and 2018, and holds it in a relatively easily accessible data set in NHS Scotland. And that includes CT and brain images, the images themselves, as well as image reports, and has linked those to hospitalization and death and to prescription, allowing us to make some inferences of the imaging that we see, either relative to the image reports or to future health. And we're working on how to make access to those data as simple and streamlined as possible for researchers like you. Next, personal monitoring for stroke. Clearly, this is going to be a major growth area. So for wearables, things we wear on our wrist with our Fitbits or our Apple Watches, Apple Watches have an atrial fibrillation detection algorithm. So what's the reliability? So questions we might answer about what's the reliability of that when using personal devices? Can we use these personal devices to make recommendations about care for people with stroke, for example, after falls, or if they're not as mobile as we expect? The challenge there is the regulatory environment, so we'll be investigating that. Can we use these devices to measure impairments? Currently, impairments are measured in great detail by clinicians, but what is the correlation between impairments measured by watches with impairments measured by clinicians? And there are much more simple personal monitoring devices that are used at greater scale, for example, blood pressure measurements, and there are data sets available at national scale on blood pressure measurement, and we want to see if we can implement and use those existing data for research. So I've spoken, that's our first that's the first 4 themes. What I'm going to talk about now is the theme that many people are interested in who've joined the call today, which is using population level data. So the data set that the BHF Data Science Centre has worked with most and has gone to quite some way down the line to develop is held by the NHS England Trusted Research Environment, or Secure Data Environment, that was linked together for the use of for COVID-19 research. And so there's been a lot of work to curate a data set at a whole English population level. And what that does is it takes COVID-19 data, for example, from vaccinations and lab tests, data from the health service itself, so hospital data, death registry data, community dispensing, e-prescribing, as well as intensive care use, and then data from specialist services. And the one for us that we're most interested in here is the Sentinel Stroke Audit Programme, where we've linked the first 72 hours of data from that registry to all of these other data sets. But other things are also available, for example, coronary intervention, cancer, and many others. And these are linked together with the pseudo identifiers, and the data set is then held within the trusted research environment. And that de-identified linked data set is being used by people who've joined the CBD COVID UK consortium to produce a number of outputs which have been influential for public health, particularly around COVID. Data can leave that environment after checking, and algorithms can come into that environment after checking as well. And much of the work on this has been led by Angela Wood, who's leading this theme and is the Professor of Medical Statistics at the University of Cambridge. Within these data sets, we've gone some way to defining what stroke looks like. This is work led by Spiros Danaxis, who leads the Defining Disease theme, working together with Jamie Farrell. So this is looking at what stroke looks like, linking data from the stroke audit, from hospital admissions, and from GP admissions. And this Venn diagram is produced by looking across those data to find everybody who's had a stroke. And for everybody who's had a stroke, we've taken the earliest date of a stroke record and excluded people who've died within 7 days. And we've looked for another stroke record within 30 days of that stroke admission. Sometimes we found another record and sometimes we haven't. And this looks at the overlap between those data sources. So what we can see here is that if we only use data from the stroke audit, which we know is very carefully phenotyped, which is an advantage because every single person has been reviewed to some extent by a clinician. If we looked at the overlap between people in the stroke audit and these other data sets, we see quite a reasonable number of people are missing. There are a number of people who are not in the hospital admissions data, who can only be seen in the hospital admissions data, or can only be seen in GP data. It's about a quarter of people where there is a record of stroke who are only seen within GP data. So looking at these linked data sets is going to give us a much better idea of stroke in its entirety across the United Kingdom. And look, using these, it allows us to do a number of research questions at its most simplest. We can just measure something like incidence of stroke. So this is now just looking at hospital episode statistics and deaths only, work done by Dr. Wen Shi and Dr. Elias Alaria at the University of Cambridge. And this is looking at the effect of COVID on stroke and myocardial infarction incidence. And you can see along the horizontal axis at time since the beginning of the pandemic in January 2020, and along the vertical axis, the incidence rate per 100,000 people. And what you can see, first of all, is stroke is in green, myocardial infarction in red. First of all, you can see the incidence of stroke tends to be higher. Stroke is an important cardiovascular disorder, and often it seems to be the Cinderella to myocardial infarction, but you can see here is a really important cardiovascular disease. We can see the effect of the first COVID wave on healthcare as reduction. There's an enormous reduction in admissions. And then we see this slight increase after the second COVID wave, which has led to some concern by the chief medical officers of the UK nations to see whether we can reduce this incidence. We then used it for other research. So, for example, we've been looking at the thrombosis risk after COVID-19. So here again, taking what we've heard, the entirety of the English population registered with a GP at the beginning of the pandemic in January 2020. We've measured all diagnoses of COVID-19 by people who've had a PCR test or were admitted seen their GP or admitted to hospital with a COVID-19 diagnosis, and looked at everybody who'd had either a venous thrombosis or an arterial thrombosis to tell us about blood clots. So the venous thromboses were deep venous thrombosis or clots in the legs, the lung thromboses, pulmonary emboli. We've looked at clots in ischemic stroke as one of our arterial thromboses and myocardial infarction. And you can see the substantial numbers of people who've been affected by these conditions we've been able to analyze. So about 57,000 venous thromboses and about 250,000 arterial thromboses. And this is what this found. So this is work done by Angela Wood, Rochelle Knight and Jonathan Stern in Bristol. So this is, if you look here, we've got two graphs. On the left, we've got the risks of arterial clots, and on the right, the risk of venous clots. And on the x-axis, time since someone was infected by COVID-19. Along the vertical axis, the hazard ratio, that's to say how much more likely someone who's just had a COVID-19 diagnosis is to have one of these conditions compared to someone who doesn't have a COVID-19 diagnosis. And we've got the dark red line, which are people who were hospitalized with COVID, and the light red line, which are people who weren't. And you can see there's something similar about these two graphs. There's a high early risk of both of these conditions, which for arterial thrombosis falls quite quickly. So by the time you're about 3 months, your risk isn't very much higher than if you'd never had an infection at all. It remains a little higher if you were hospitalized. But for venous clots, we can see that for both hospitalized and non-hospitalized people, this risk remains elevated, never entirely goes back to normal. We've done some work subsequently on this. This is research done in the first wave of COVID when there was a particular concern about these risks. And in work led by Genevieve Kezard, also from Cambridge, which has shown the effect of vaccination in markedly reducing these risks. So with those are some examples of the question we have answered, but remember there are many other questions we could answer with these health systems data. We could ask whether deprivation is associated with stroke differently across the United Kingdom. What percentage, for example, of stroke patients have a patent foramen ovale closed in English NHS trusts? What multi-morbidities are most associated with stroke risk? How do air temperature and pollution affect stroke incidence? So Angela Wood has worked very hard to bring in pollution data to link to these data sets. How many strokes occur due to underuse of vascular secondary prevention? These are just a few questions I came up with myself on my bicycle, and I'm sure that you will think of many, many yourself. So these data now are open for new stroke projects, but they need to have a COVID angle. For people who sign up to the CVD COVID UK consortium, data access will be free. We are going to try and provide support for experienced analysts from the BHF Data Science Centre team. The questions do need to have a COVID angle, but importantly, we're also offering two £25,000 grants to projects who wish to apply. So this is our call for projects. So we're going to fund 2 projects which give support of the Data Science Centre analytic team to people who want to be in the environment, and that £25,000 to support analysts wherever they are. So we will try and select projects. We will have to select projects which have a stroke and a COVID theme. We will need questions which have either a James Lind Alliance priority or an NHS priority as part of their question, because the James Lind Alliance has already defined the research priorities for people with stroke. We don't need to start that exercise again. You need to be in an institution that's already part of the BHF Data Science Centre agreement with NHS England. And if you look at the call for projects by scanning this QR code, you'll see where those places are. You'll need to make sure your research is feasible with the CVD COVID UK consortium data, which is the linked data that I've been describing to you. If you've got any questions, just email myself or Sarah. And you need to sign up to the Principles of Open Science, which I hope all of you would do anyway. The timeline is quite short. We'd like the deadline for submissions the 17th of February. We'll inform successful candidates a couple of weeks after, and you need to be ready to start your project at the beginning of April. And the date that we expect these projects to last about a year. So we're looking for deliverability and people who are ready to go quite quickly. If you look under this QR code, you'll find more information. If you need more information, email either myself or Sarah. And the link is at the bottom if you want to look at it later. So to summarize for everybody, what we know now is there's a fire hose of stroke data ready to be used. And for us as researchers, what we need to do with it is we need to make tests of stroke treatments cheaper and faster. So that's randomized trials. We need to speed up the quality of care that's delivered by the NHS to people with stroke or people who need to have their stroke prevented. And we need to deliver useful information for healthcare systems, whether that's your own hospital, whether that's at a region, or whether that's nationally. And the Stroke Data Science Catalyst, with its support from HDR UK, from the BHF and from Stroke Association, aims to set a course for the use of these data with patients and the public. We're supporting this opportunity for analysis in primary care and SNAP this year, particularly for COVID questions. We're going to be developing brain imaging, stroke phenotyping and cohorts questions, and planning the path to registry-based studies in both the Scottish and the English registries. Any questions, email us both, or put them in the chat now, and we can answer them for you. So thank you very much for your attention. So over to questions. So just having a quick look what we've got in the questions. So the first question I've got is how we're going to use these data to address equity of care. So clearly, perhaps Richard would like to speak to this in a minute. He's spoken about how providing equitable care across the United Kingdom and investigating inequalities such as through deprivation and ethnicity is important. We have these information in these linked data, so people who want to get going with it very quickly can start to look at COVID-related themes. And then if you contact us in the centre, there are a number of other data sets we can support where you can answer these important questions in stroke care. Richard, I don't know if you want to add anything to that.
Yes, so obviously understanding the problem is one of the first steps. We're really keen as the Stroke Association to understand the data and then also be able to use this to inform how we work with policy and decision makers, and that's nationally and locally. So where we at the Stroke Association want to try and influence policy change and also allocation of funding to services, this kind of data and information will be really critical.
Thanks, Richard. Okay, so question from Jacqueline. Could you clarify whether and how we can access these data if the project is not part of the funding call described? Yep, so if you would like to join the CVD COVID UK consortium, email either Sarah or email the BHF Data Science Centre and we can get you onboarded into the consortium. It's important that we get as many people working with these data as possible. It's been a great opportunity. It's highly curated, and I think you'll find the other researchers who are using it are very supportive, and so it's a real learning opportunity. Okay, just going down my questions list. We've got another one from Fred Van Wee. Is it the case that projects must address a stroke and COVID element, or can it focus on a JLA stroke query? So for our call, the data that we're using has been developed specifically for the purpose of COVID-related research. Now, what we mean by COVID-related, so it does need to have a COVID theme, but it doesn't need to be that the research project is entirely about COVID. It doesn't need to necessarily say, does stroke infection increase the risk of stroke? You could, for example, look at the effect of the pandemic on particular aspects of care. So, for example, the use of rehabilitation, if we could measure that in the data set, and how that has changed from the pandemic till afterwards. So we might be looking at the period before the pandemic, during the pandemic, and after the pandemic to see how that's changed. And that's a very reasonable way of using these data, and people have used that to address questions that aren't just relevant to COVID, but relevant to healthcare in general. Okay. Another question, this call for funding has a tight turnaround. Why is this? Well, the reason we've got such a tight turnaround is we want to make this CVD COVID UK data set used as quickly as possible. The permissions we're allowed to use the data for about the next year. It's been highly curated. It's really as easy to use as a very large data set can be. And again, there's a really supportive community working around it. So those are the reasons why we're trying to get it done as quickly as possible. Also, for someone like Richard, he wants to see early success of the centre. So if you're able to show that stroke, that the research into stroke can be benefited by the use of data science, we want to do that quickly rather than slowly, because people are having too many strokes. Another question, will there be any future opportunities for funding? So if you're, BHF Data Science Centre and the Stroke Catalyst, we're very, very happy to support applications that you wish to make to other funders. And Richard has spoken about the opportunities from the Stroke Association, but there are similar opportunities from the NAHR and for the British Heart Foundation, and we're very, very happy to support those. In terms of more funding from the BHF Data Science Centre, there's nothing immediately planned, but many things are coming up constantly from the HDR UK. So if you join our communities, we'll help to let you know what's happening about those. Okay, any more questions from anybody? Here we go. So let's see. So people are asking about whether we're going to share the slides, and the answer is definitely we will be sharing the slides with everybody. Are we a partner of Eden? So this is thinking about the European environment. We will do our best. We will do our best to be part of European initiatives. We're particularly interested in the BHF Data Science Centre and collaborating with other national audits, so those in Germany, those in Sweden, and those in Denmark, to make sure that we can benefit the stroke audits here. Okay, the next question is, does this call allow linking of project data sets to the TRE data? So currently, this is using the data that's sitting within the trusted research environment. However, linking of external data sets to NHS England, Scotland and Wales data is the priority for Reacher Sofat, who's leading the cohorts team. So we're very happy to put you in contact with Reacher in her environment, where she's really developing a new governance structure to make linkage of data, external data sets easier to NHS England. I myself have found it very difficult to do this in the past. I've spent many years trying to link randomized controlled trial data to data held in NHS England and NHS Scotland. And so Reacher's initiative, I think, will be valuable to all of us who are researching this area. Great. So any other questions here? So we haven't got any other questions. Richard, anything you wanted to mention about data science in general, and how you think the Stroke Association might be able to help?
Yes, as I mentioned earlier, we also fund our capacity building. We know that currently, obviously, stroke research community is quite small, and there's even fewer data scientists working in stroke. So that's an area that we would like to see increasing. Obviously, we have our own fellowships and lectureship schemes, and I know that obviously the NIHR have their own academy. So I'd also urge people to kind of look at those and see if you have colleagues that are interested or might be suitable for those. I think it's an area that we would like to see the number of people working in stroke data science increase over the coming years.
Great. Sarah, anything you wanted to mention last off?
No, I don't think so, but please do get in touch and I'll give anyone an opportunity if anyone wants to just pop their hand up. Anything that anybody wants to raise? Nope. Okay. So we've got the email address. Sarah popped the email address for the Data Science Centre in the chat. Please do get in touch with us. Will's also shared my email address. I'll pop that in the chat just before we finish as well. If you get any questions that come to you after this, please do get in touch with us. We'd love to have a chat with you. And the webinar has been recorded and will be on the HDR UK channel tomorrow.
Great.
Thank you everyone for attending. We're really grateful for your time.
Yeah, thanks everybody for coming. We're always open to your ideas. So just if you've got thoughts, ideas, things we're missing out on and need to do let us know. So thanks very much, and we'll say goodbye for now, and hopefully we'll get some applications from many of you and hear from you in the rest of the Catalyst. Thanks very much.
Thanks everyone.
Bye.
Thank you. Bye.
Bye.